Good morning, everyone. I see there's few of you here than there were yesterday, so welcome back for those of you who are back again, and nice to see you. I hope everyone had a fabulous time yesterday and didn't get too cold last night down at the marina. It's classic for those of you not from the Bay Area. Yeah, classic Berkeley summer. Bring a parka. So I just wanted to give a couple of reminders before we get into our panel this morning. First of all, just the winners have been being announced of the raffle winners have been being announced as they on Slack, email, and on the website, the UC Tech website. So hopefully all of you have been checking to see whether your name is on there. There's some really cool prizes. So I hope some of you have been winners, because I sure like some of those. I would like to be a winner someday. I'm usually not. It's one of those weird things. I don't know if others of you are like, I never win anything. I don't. But anyway, check to see if your name is up there and claim it by noon today, because if not, if you don't claim it by noon, it's going to get re-raffled to some other lucky person at 1 o'clock this afternoon. So that's one important reminder. Another reminder is that the sponsor showcase is still running today from 11 until 1:45. So please, if you haven't had a chance to go see our vendors, check them out and see what they have to offer. I think they would appreciate it. And they certainly have been incredibly generous in allowing us to put this whole thing on. And then next, I'd like to really get to the main part of our show, which is to welcome back Joe Bengfort, our CIO from UCSF, who put together this amazing health equity panel for us today. So, and Joe's going to introduce our panelists. So thank you, Joe.
Good morning, everybody. Thanks for being back again. What a great time we're having here. I want you to check something out here. I'm all dry, no accidents. It's really awesome. We call that a start to a really good day at my age. And the ceremony last night, how many of you were able to go to the ceremony? Great, a lot of people. It was a fantastic time. We almost froze to death. It was incredible. But congratulations to all the award winners. It could have been a whole lot worse on the cold side. So I want to tell you a quick story. I'm on the planning committee for this. Faye Snowden, the awesome Faye Snowden, was running all these planning committees. And I joined the very first meeting and I said, I have this great idea. Let's rent a party boat and let's pile everybody on the boat and let's float. This is true. Let's go out to the middle of the bay, right between San Francisco and Berkeley. And let's do the award ceremony out there. It's going to be fantastic. What a great metaphor about our, our partnership and all that stuff. So just imagine if we'd have been on a boat last night, right? With the wind and the cold and the waves. I mean, we'd have had a lot more accidents than when I had yesterday. Faye approached me after the meeting. She's like, I know how busy you are, so you don't really have to come to all these meetings. She's really awesome. I do want to take a second and just say there's so many people that need to be thanked for this session, but I want to single out Faye Snowden. Faye, can you stand up for a second? She is just an awesome leader. I was so impressed, and my recruiters are already hard at work. Listen, I'm here first. My real job here is to introduce this topic and our panel facilitator. The topic here is essentially in the area of health equity. And if you were paying attention to what happened during the COVID pandemic, it really highlighted and spotlighted how big of an issue health equity is in the United States, probably in the world, but really focused here in the United States. It really depended a lot, how you were impacted by COVID, what the outcomes were, the mortality rate, all these things were impacted by where you lived, the color of your skin, where you are on the socioeconomic chain. Just an awful situation, but it is the reality that we live in. And at the University of California, I'm really proud of the fact that we have so many great leaders, researchers, educators, executives that understand this and have been hard at work at this for a long time. There's a long way to go, a long way to go. But we've got a great session here to talk about all of this. Now, you might have a question about why are we talking about this at an IT conference? So I want to give you my perspective on that. Think about this, how what we do scales, right? And I think about it from like back when I was doing network stuff and things of that nature. I could make one mistake, and I could take down an entire hospital system and you know, all the administration, they could be down for hours. I know because I did it, right? So one little step by one silly person, and all of a sudden we have this big impact. Now in today's day, with algorithms and analytics and all the programming that we do, it's just the AI, right? The things that we're doing, that you're doing, whether you're a programmer or a data scientist or whatever, the things that you're doing scale out not just to our institutions, they scale out across society. Doing your job well and really considering the impact on health equity. And you can actually change what's happening in society. You can change what we saw. The power that you have at the end of your fingertips, at your home in your pajamas, doing your job is really massive. And so I just want you to have that in mind as you listen to this. And I hope you go back to your campus with a real passion and a sense of responsibility for how important the work you do really is and how it scales. Okay, let's talk a little bit about our panel moderator. He is a person of great passion in this space. His name is Dr. Aaron Neinstein. He's a faculty member at UCSF in endocrinology. He spent the last decade as a key leader in clinical informatics and digital health. He's most recently was the vice president of digital health for UCSF. I've had the pleasure of working with him for several years. He's represented UCSF and the UC health system at a national level on digital health topics, and really just a strong advocate for patient experience, for equity. I mean, he really works hard in all the digital work that he's done to make sure we're putting the lens of equity and experience on all of that work. And so now Dr. Neinstein has just accepted a role as the Chief Medical Officer at Notable Health. So he's in the doghouse with me right now, but I'm proud to say that he's going to continue his clinical affiliation at UCSF. So let me introduce to you my friend and colleague, Dr. Aaron Neinstein. Dr. Aaron Neinstein. Oh yeah, there he is.
We're just way back there. All right, good morning.
Good morning.
Thank you, Joe, for the great introduction. Would love to just quickly introduce our great panelists here, and then we will dive into the conversation. So Dr. Crystal Sine is Chief Administrative Officer for Equity, Diversity, and Inclusion, Associate Chief Medical Officer for Health Equity at UC San Diego Health. She focuses on creating equitable, diverse, inclusive environment for students, trainees, faculty, students, and patients. She's also professor of clinical medicine at UC San Diego School of Medicine. She's responsible for the vision, leadership, and strategic direction of UC San Diego's justice, equity, diversity, and inclusion initiatives. She partners closely with leaders within the organization to ensure anti-racist, equitable, diverse, and inclusive strategies are implemented across the health system, and is also a prolific researcher with more than 75 peer-reviewed publications and really nationally recognized work as a health equity researcher. One fun fact about Dr. Sine, she lived and worked in Ghana, West Africa for 3 months on a research project with traditional birth attendants in remote villages. But when she got there, Because of the language barrier, she actually lived with the wrong family for a week. So we are very grateful that she made it to the right stage this morning.
That's true.
And welcome, Dr.
Thank
Sinead.
you.
Dr. Medell Briggs-Mallinson is Chief of Health Equity, Diversity, and Inclusion for UCLA Hospital and Clinic System. She's also an Associate Professor of Emergency Medicine, also at David Geffen School of Medicine at UCLA. So in her role, she's responsible for implementation and oversight of organizational structures and initiatives promoting inclusivity and equity among UCLA health staff, patients, and communities. And she really prides herself on building a culture of innovation, collaboration, and excellence, and also a very nationally recognized healthcare improvement advisor, speaker, and author, building excellence in health equity within diverse communities, as well as innovative healthcare system redesign. I actually am very fortunate to also know her in her other role. She's currently the co-chair of Health and Human Services Office of the National Coordinator Health Information Technology Advisory Committee, also known as HITAC. So fun fact for Dr. Briggs-Mallinson, she had the opportunity earlier in her career to build a brand new healthcare organization and hospital from scratch for the community of South Los Angeles. And her first job, which she is not wearing on stage today, was as Santa's elf at 15 years old. So please welcome Dr. Briggs-Mallinson. Yeah. And last but not least is Dr. Courtney Lyles, who's Professor of Public Health Sciences at UC Davis School of Medicine and Director of the UC Davis Center for Healthcare Policy and Research. Very recently, she was on faculty at UCSF in the Division of General Medicine at Zuckerberg San Francisco General Hospital. She has led informatics infrastructure programs, co-directed the UCSF CTSI Innovation in Research and Informatics Core, and she holds multiple research grants on digital health equity, spanning digital health design, testing, evaluation, and implementation, and has led several large studies in both clinical and community settings around chronic disease, diabetes, depression, hypertension treatment, and community health resources. Dr. Lyles is the youngest of 5 children, and of those 5, 3 of them are left-handed, including her 2 adopted siblings and Dr. Lyles. So welcome.
Thanks.
All right. So we have an amazing discussion here. So just to kick us off, would love to maybe go down the line here, starting with you, Dr. Sinead. If you can say a few words within the University of California and within your specific campus, where are we in addressing equity and disparities? What do you see? Let's kind of set the table here. What do you see as some of the top challenges and opportunities?
Okay, thank you, Aaron. So I think, let me just start more globally, I guess I'll say, or at least nationally. In 2003, there was a landmark report from the Institute of, what was then called the Institute of Medicine, now the National Academies of Medicine. And it really was a really seminal report for documenting sort of the state of health disparities in the US. And that really showed us that racial and ethnic disparities in particular were persistent and pervasive, and you could see them pretty much across every condition and every process within healthcare. And so we're now 20 years out from that landmark report, and there was a recent sort of workshop and kind of a revisiting of where we are in terms of addressing health inequities. And very sadly, not a lot has changed when we look at the breadth of the literature. So I'd say that that's kind of the setting the broader context for where we are. I think in terms of challenges, one of the biggest things that I see, which may resonate with some of you, but may be shocking to others of you. I think one of the biggest challenges really is the empathy gap. It's our inability to see that this person or this patient or this community that's different from the one that we identify with is worthy of having good quality, accessible healthcare. And I think that if we can really try to move past that and really see that the people who are at the margins and the communities that are at the margins deserve the same high quality, safe, timely care, all of those things that really constitute what healthcare should be, then we would make a lot more progress on addressing health inequities than we have today. So I'll turn it over to my colleague.
Well, thank you for that. And I'm going to build upon some of those pieces. Since we are talking about some of the landmark studies, another one that came out was in 2001 from the Institute of Medicine, which is now known as the National Academies of Medicine. And this was crossing the quality chasm. So those of us in healthcare, we all know, like, you cannot go into a hospital or a clinic and say, we don't have to give high quality care to people. No one would ever say that. But part of this was that one of the primary fundamental pieces of providing high quality care is that it has to be equitable. And this was defined all the way back in 2001. However, for some reason, only now after the pandemic, and only now after our significant racial reckoning in this country of identifying the injustices, are we now all taking a step back and saying, like, well, what does equitable even mean? And so to build up even what my colleague, what Dr. Sine mentioned, I think that this is our time. And this is our time for multiple reasons. The reason why we haven't seen improvement in all of the various different areas of, I like to call them health inequities versus disparities, because inequities are rooted in injustices, okay? Inequities are rooted in injustices. And we know, especially within healthcare, that although we can pride ourselves as being doctors and nurses and other healthcare professionals, one's overall health and well-being is actually made up of 80% of factors that exist outside of hospitals, clinics, and emergency departments. It actually exists with the factors that all of us as individuals face in our communities. And there's many different social drivers of health. And so in order for us to truly make sure that everyone can be as healthy as possible, we have to focus on that 80%. We have to focus on education. We have to focus on making sure that everyone has economic opportunities. We have to focus and make sure that we don't have food deserts. And that, in order to do that, that takes we as a country, we as society in order to do so. And so that's also on a much larger national scale. As I said, I think this is the time for opportunity. At UCLA and UCLA Health in particular, we have put in place many different structures, committees, as well as policies, and most importantly, community partnered initiatives to address those social drivers of health, because we can get the best care in our hospitals, but if we're not making sure that that young child has access to high quality education, or their family has access to true high performing jobs so that they can feed their family, make sure to buy houses, and for us to get rid of all of the various different legacy systems that have perpetuated racism, as well as other forms of discrimination, we're not going to improve our overall outcomes. So those are some of the things that not only we are doing at UCLA Health, but also that what we need to do as a society.
Yeah, thank you so much. I literally was going to say the same two concepts as my colleagues up here, so I know I'm on the right panel. I was going to talk about the unequal treatment report and how little progress we've made over the past 20 plus years. And I was going to talk about the increasing awareness of social and structural drivers of health outcomes, and that even if we improved all healthcare processes, which we have not, we would still not be able to meet and address the inequities that have been in place for really centuries within our country. So those are two really important concepts to think about. And I think what I'll add to that is really thinking about the pandemic and the roles of working across health systems, public health departments, community-based organizations, like my colleagues also mentioned, just thinking differently about the types of partnerships and the types of data that we have together to really understand what programs we're implementing and where we're making change, I think is an opportunity space. And so I feel like there has been a moment in time now where we did things differently. I feel it almost slipping away after the pandemic in terms of the public health and healthcare system partnerships. And I hope we can continue to invest in some of those because we won't be able to do it within our own silos. And then the last comment, and then I promise I'll stop talking, is really about universities as being a really important place to do this work. We have health systems, which we are all tied to, and we'll talk about a lot today, but we also have the entire academic institution, right? Across the social, sociology, anthropology, history, those are all extremely important for us to actually make progress. And how do we leverage all of that is sort of something that I'm really interested in, passionate about in this UC-wide community.
Thank you so much for setting the table for us. So actually, let's have you keep talking and come back down this way. So let's double click one layer down. So we talked kind of at a high level, the state of affairs across the country and in the state. Can you give maybe one example from each of your areas, each of your campuses? We have great representation here from across the UC system. So unfortunately, we only have 3 campuses represented on stage, so not everybody in the crowd, but maybe give one example of a particular program that's active now, or a research study, or something that you feel like is moving the ball forward and where there's learnings and progress in this area.
Yeah, there's a lot of examples. I think the one that I'll highlight in terms of, because I think it'll lead into our broader discussion about how we measure, how do we make change at a system level, is you mentioned I just came from San Francisco General Hospital, where I'd been for almost 12 years. And so it's the public hospital sister of our UC systems, where we practice and do research. And I think, like all of our UC systems, we have true north metrics about what we're trying to achieve in terms of our quality improvement outcomes. Health equity has been a true north metric at San Francisco General for, I don't know, very long time, maybe a decade or more. And an example from that is really seeing a rather mission statement, a vision statement of we want to achieve health equity as an organizational priority for our institution. And then being a part of that, we're watching how they take their data, how they take something just like hypertension equity and think about the overall measurement of that in their clinics, the overall improvement they're making, and then specific places, specific areas where they want to do concrete programs like food pantries in clinics, additional outreach with remote blood pressure monitors. Like, how do you take a metric and how do you turn that into something that's concrete and actionable, and then use those metrics to evaluate how you're doing and to hold yourself, frankly, accountable for what you're doing and what kind of progress you've been making. So that's sort of an example at a system level that I think is something that can be replicated regardless of whether you're in quality improvement or in research or another area. What is the goal? How do you make that into an actionable strategy? And then how do you use those data to drive accountability and improvement over time? Yeah.
So we've done several things as well at UCLA Health, and the way that we proceed is with intentionality and strategy. Just as we proceed in which we want to improve achievement in any other area, whether it is our data analytics performance or whether it is graduation rates at a campus, well, we have taken a very intentional approach to ensuring that we are advancing equity and justice within our organization. And so we actually divide into 3 primary pillars: our people, our patients, and our community. And with our people, really taking a look of how we're building an inclusive environment where everybody feels a sense of belonging, everybody feels a sense of respect, and most importantly, everyone feels that they can also achieve and contribute to the organization. And we've done that by holding numerous different sessions. We've expanded our affinity groups in which all people, all the various different groups come together and support each other, and just really making sure to reinforce our values and our values of how we interact with one another. Not just, for instance, we say this starting from our very top senior executive leadership. In terms of even our people, we have also put in place, our patients, we put in place additional true oversight structures. So we have now what's called an equity council, which I chair, but it includes all of the senior leadership, our president, our COO, our CNO, our CMO, everyone, all the C-suite, plus others, and then also our health equity experts, where we oversee all that we're doing within the organization to ensure that we're aligning and making sure that we're moving forward. And there's accountability for the goals that we create. And part of that Equity Council, we now have something called the Equitable Care Committee, in which we also have representatives to say, what are our goals? What are our priorities in order to decrease the inequities that exist within our system? Who's being held accountable, and what is all of our contribution to it? So the same way that you would set goals for any other metric or any other effort, we do that for health equity and justice. And then the last piece is our community. And one of the things that we have done extensively is, as I mentioned, it is not about going into community and extracting information or telling community what they need. It is about going into community and partnering and saying, we are here to help. We will bring all of our assets, our intellectual assets, our financial assets, anything. We want to know what you need and how we can make sure that we partner with you to make our community stronger, healthier, and making sure that they can thrive. And so we've done that through, and by the way, especially all the UC health systems, but also hopefully then all the UC campuses will be part of what we call the anchor network, where we as UC campuses serve as anchor institutions within our communities in order to improve both racial and social economic inequities. And we do that from inclusive hiring, inclusive procurement. We at UCLA, we also focus on environmental justice, but then also place-based investments, where we are putting money into the community to address all those social, structural, political drivers that we know impact overall well-being. And so we have already many of us as UC campuses that are part of this anchor network, and our goal is to get every single campus. So just to let you all know, it's coming. But those are just some of the things that we're doing right now to really make sure that we keep this window of opportunity open and we are achieving our goals of ensuring that we get to justice, not just equity, justice. That is the final destination.
So yeah, I was going to mention the Healthcare Anchor Network as well, but let me step back a minute. So at UC San Diego Health, and I have, a dual role kind of in the health system as well as on the academic side in the School of Medicine. We're pretty new on this journey. I just came from University of North Carolina at Chapel Hill, where I was on the faculty for 13 years. So coming to UC San Diego, the organization is relatively sort of new to this journey of health equity and health justice. And one of the things we had actually decided to make dismantling structural racism a strategic pillar within our organization's framework, operational framework. And that was decided right before I came, and then I was recruited into this position. So this is I'm in an inaugural role in this position in the health system. And I felt it was really important that if we're going to make a bold statement like dismantling structural racism, we need all of our leaders in our organization really needs to understand what that means. What does that look like in your day-to-day work? And what can you do to actually dismantle structural racism? And the reason that's important and how it relates to equity is that we know in order for people to achieve health equity, that we have to address those social and structural barriers that cause inequities. And racism is one of the structural barriers. And so as Medell mentioned, part of what we did was we made it part of our organizational goal. So it's tied to the incentive structure of all of our leaders, that they understand what that means. So the way that we did that was we had 3 different knowledge building sessions, each 90 minutes that all of our leaders had to participate in or got the opportunity, I should say, to participate in, where we really talked about what is race, this social construct that many people assume is biological. We talked about what is race and racism and how did we get here? Because it's really important to take a historical perspective when we're talking about this. It's such a divisive topic, and many people kind of hear it and automatically have a visceral reaction. And so we wanted to kind of level set around what is race and racism. We wanted to talk about how do we create safe, brave, and accountable spaces to have dialogue about race and racism and other structural inequities. And then we wanted to talk about power and privilege, because we certainly talk about oppression a lot in the space of health equity or health inequities, but we don't often talk about privilege, which is, if you think about them as a seesaw, it's the opposite end of that seesaw. So we had those 3 sessions, but what we also did was we had facilitated discussions with our leaders, each of our over 300 leaders at the director level and above, with those leaders and their teams, where I used a TED Talk from a physician, social epidemiologist, and leading anti-racism scholar. We used these TED Talks, and they were allegories on race and racism. And I had facilitated discussions with all of those teams. So by now we've done this with over 3,000 people probably, where we could have really honest discussions about structural racism, and people had a chance to share and express how they felt and, thinking about it in a different way. And I think using that lens of allegories or stories really helped to take down the temperature when you're talking about these things. And I think it helped our teams to really see and understand racism at the structural level. So what does that mean in terms of how we make decisions, who's at the table, who's not, whose voice is heard, is not. And it depersonalizes from that interpersonal level that we often think about when we hear race. I don't like you because of you're Black or you're this or you're that, right? So we really talked about it at that level. And I think that was really helpful for people to be able to feel comfortable having these dialogues in a facilitated session where there was someone who knew how to have these dialogues. And we related that to health equity. So how does that show up for you in the work that you do in your service area? And we followed that up. So we did that. We did some videos, because people also need to be able to consume the content on their own. So we developed really short videos about why do we lead with race? Because some of the questions that we would get were, well, why are we talking about race? There are many other aspects of inequity, which there are. Why do we lead with race? And so I felt that it was really important that we give people that understanding. And we all know, like, we don't want to do the thing that's uncomfortable. And talking about race is the most uncomfortable. So I felt that it was really important that we actually have those discussions. And then once we tackle that, it'll be so much easier to do some of the other things. So we've been doing that and kind of had some continuations from those. I'll stop there.
Fantastic. Really a great mix of programs that you all described. So, we have an audience of IT professionals here. Would love, thinking about each of those programs. Dr. Lyles, you talked about data at the San Francisco General Hospital, looking at inequities. Dr. Briggs Mallinson, you talked about the anchor institutions that the UC campuses are participating in, and sort of community engagement. And Dr. Sine, you talked about dismantling structural racism on campus. So thinking about those initiatives in the context of the life of an IT professional, what is one or two ways in which our audience here might be able to go back to their job tomorrow and engage in these types of initiatives on their campus? Dr. Lyles, let's start
Sure,
with
I'll
you.
start again.
Yeah.
I think the theme that I'm picking up on in all of our remarks is really about, first, the awareness that even when you're rolling out new tech products or you're building teams to deliver tech infrastructure at your institution, that there are many levels at play in terms of equity and how it shows up. It's not just about an individual patient using a health app, or an individual clinician, or even an individual staff member or team member taking something up. It actually starts much earlier than that, and just the awareness of that to me is the first step, which I think Crystal was sort of alluding to. Bringing everyone to the same level playing field is something that all of us in this room can do. And then the second theme I heard was really about measurement and not being too narrow in how you're thinking about success of your programs. so I work in patient-facing technology specifically. So if we're rolling out a new telemedicine platform, or we're offering patients many amazing apps or tools that we'll cover in our healthcare system, if you only look at, did the hemoglobin A1C or did their blood pressure improve, and you're not thinking about all of the other steps that come before that, and how it was set up, who has access to it, how it was offered to them, how it related to their relationship with their clinician or their relationship with their family or in their community, you're going to make a decision about a program that's tech oriented that actually could reinforce disparities or equity, when rather than thinking about what are my opportunities across these. I can't change every single thing. How can I have my eyes open? How can I work across these domains and make some decisions about how we'd roll it out or how we communicated about it that actually is informed in partnership with the people that we want to use the technology that we're developing and rolling out. So those are the two themes that I'm hearing, and I think that will bring all of our work into a different place.
I'm happy to go next, and I agree with those points. So I'm going to put on my different hat. I'm going to put on my techie hat, because I am one of you all in more ways than one. I am all about technology, and especially health technology. And that's where my kind of passion is, that intersectionality between health equity and justice and technology. So first, I would say, when you're thinking about, and all of you all especially are in different areas of technology. Some of you all may actually be in systems design. You all may be in privacy. You may actually be in the true data analytics or the back end. You may be in UX, UI, whatever. I don't know what everybody's in right now, but I will tell you this. I will say that when you are thinking about whether it's design, implementation, monitoring, whatever it may be, think about it with an inclusive lens. And what I mean by that, if there's a brand new product that you all are looking at, when you're looking at that product, say, is this advantaging some people or disadvantaging others? Go through those various different groups, because especially here within our campuses, we tend to sometimes roll out products. Unfortunately, we have new structures in place to prevent this. But if somebody is living with either a cognitive or a physical diverse ability, how does that impact them? Can they use that system that we are getting ready to deploy? So think about everything from an inclusive lens of saying, will this benefit or disadvantage one group or another? In addition, I always say there's 3 critical errors that we sometimes do when it comes to data analytics, as well as use of data. The very first critical error that we do is that we have biased collection of data. The second critical error is actually biased interpretation of data. And the third critical error is interpretation of biased data. You understand? 3 areas of potential bias. So I want you all to go back and keep those 3 critical errors in your mind so you do not make them, because I see it so often in our technology. And because of that, what happens is either we perpetuate inequities or we create inequities. And each and every single one of you all has the ability to make sure that does not happen. Okay, so that would be my main advice from all of you all as IT professionals. And we thank you for your service, because you all do such an amazing job. Shout out to my UCLA Health IT team, first of all, love them to death. And I will tell you, a lot of our different efforts, even at UCLA Health, we could have never achieved them without the partnership, the brilliance, all of the efforts that came from our health IT teams. And I am incredibly indebted to both the leadership and all of my team that has worked with me throughout all of our efforts at UCLA Health. So special thank you to my IT teams.
That's great. I think my colleagues talked about several of the things that I was going to say, but maybe I'll put just a fine point on a couple things. So Courtney was talking about when we're thinking about what's our metric for success, and often we go to that kind of more distal health outcome. But I think inherent in her remarks is the fact that equity is really about equity in the process and processes as well as the outcome. So that's the thing that I would say when you're thinking about whatever you're designing or rolling out, really interrogate that process and think about, is there equity in the process also? So, you know, Bedell was talking about when you're designing, use an inclusive lens, but thinking about, you know, who's going to benefit, right? Who's benefiting, who's being burdened, who's at the table when you're making those decisions. Kind of look around the room. And it's not just about racial and ethnic diversity. That's the most visible, right? Skin color is the main indicator of race in this country. And so that becomes the most visible thing. But really thinking about the diversity that's on your team so that you're getting input that's actually diverse and that you are considering a lot of different perspectives. So to do that, though, you actually have to know your team. So for me, a lot of this work, you have to do a lot of culture work in order to really drive equity. It is about the processes and the outcomes, but all of that is built on a foundation of having a culture where you understand people's perspectives, that you're seeking diversity amongst the people who are making decisions so that your products will be infused with that diverse perspective. I think the other thing that Medell was alluding to is, which I think is really important, especially when you're in the design phase, is to center at the margins, right? We often design for the average and we think about, you know, who can, you know, most people will be able to take advantage of whatever it is we're doing. But if you do that, you often will miss those people at the margins, the people who are least equipped for whatever reasons, whether it's cognitive, physical, you know, intellectual, whatever the challenge is that makes them less likely to be able to take advantage. If you don't consider them at the beginning, then you're going to miss them, right? And then it's really hard to go back. And so I think if we center and thinking about who is the group that's most likely to have challenges with this technology or whatever it is, and design so that that group understands, because the people who are, you know, on the far end, they're great with technology, or the average, the majority of us, they'll be fine, right? So design with a margin in mind. So center at the margins. I think the other thing that we often don't articulate directly, but it's really an undercurrent in all that we do, is a lot of times when you're really trying to drive towards health equity, that can't be a fast process. And often we make a lot of decisions because we need to move and implement quickly, right? And so we take a lot of shortcuts. We don't necessarily have processes and checks and balances in place to make sure that we're being inclusive and operating from an equity focused lens. And so that's often at odds with moving quickly, right? And so I think we have to really plan ahead and we have to think through things, because when you're in a rush, you got to make a decision. You're not going to get the input from, you know, that group that's most marginalized, that's more likely to not be able to understand or take advantage. You're not going to get it, or you're going to get it from, you know, patients who, or individuals who step up, who say, hey, I want to volunteer, I want to give input. But really, a lot of times those more marginalized groups that we really want to make sure are included, they're not going to be the ones who step up, because they also have all of the life challenges and circumstances that makes it harder. The last thing I'll say is, as you think about your teams, who is the person on your team who is going to really carry this banner of making sure that you're equitable and inclusive? And inclusion, that's a behavior, right? That's not, there are practical things you have to do. So who is the person on your team who is going to hold the group accountable? And it's great that if it's the C-suite leader like Medell or I, but we're not in all those meetings, right? So I think that every team, you know, every department, you have to have people there who are going to carry this, because it has to be baked in. It can't just be bolted on, right? The equity work has to infuse everything that we do. So really think about who that is on your teams. And if you don't have someone, see if you can develop that person. There are people who are more inclined. They may not be the ones who step up, but see if you can engage them and get them involved in the work.
Thank you. Really fantastic conversation. So I'm gonna ask deeper into talking about data and analytics to both Dr. Sine and Dr. Lyles, and then Dr. Briggs-Mallinson, I have a separate question for you because you already started talking about bias in data interpretation, but I'm going to come back around to your high-tech role. So for both Dr. Sine and Dr. Lyles, as we think about data, equity, measurement, analytics, what are some ways that this group can think specifically about how to use data to improve inequities and to help dismantle structural racism in their work? Where will data play a role specifically?
So
Yeah, go ahead.
I'll start. I think data is the foundation of this work, right? Data is the way that we identify where there are inequities. And data can be quantitative data, information that we get from our electronic health records. It could also be stories, but you all are probably more interested in the kind of EHR and that type of quantitative data. And so it really is the foundation. And so we have to apply an equity lens to all of our data. So when we're looking at our Tableau dashboards or whatever it is, my perspective is that all of those things need to be stratified by race, ethnicity, preferred language, gender identity, sexual orientation, some aspect of place. So whether that's a Healthy Places Index or social vulnerability, something that gives us a sense of place or zip code it could be, but we really need to be able to look at that to take a fine point at who are the groups that are benefiting and who are the groups that are not benefiting. So really, from my perspective, the data has to drive all of the work that we do to address inequities, within our patient population, not just our patients, our team members. A lot of times, the people who take care of our patients, they have inequities, they face challenges that our patients face. So we can also leverage data to understand more about them. But I think it has to really start with the data. And related to that, though, we have to really think in advance about standards. How are we going to display data? What are we going to call groups that are small sample sizes? Do we call them other? Well, no. For those of us who are in equity, we don't want to other them. How are we going to combine groups, right? It's important to have a variety of different options, right? Because we want people to see themselves. So I think we have to understand why we're doing that. I was having this discussion with my team and it was like, 10 different options for something. And it was like, but we want that because we want people to see themselves when they're completing that. They want to see that they're represented. But I think one of the challenges that we have to grapple with is then on the analytic end, how do we do those? Because often, right, I'm a researcher, so I live in this, we have these small sample sizes. We can't really make much of that. And when we try to associate those things or correlate them with outcomes, it's really hard to do because the sample sizes are too small. So I think those are things that we need to grapple with. And also, how can we do more advanced modeling and stuff within healthcare? In research, we do it all the time because research data is different from real world data. But I would love to see us in the space of real world data be able to think about what are those more advanced methods to be able to understand about our populations and how how the equity aspects relate to their health outcomes.
You said one thing I want to follow up on real quick before we go to Dr. Lyles, because I think it's an important point. I heard you say stratify all of your different important outcomes within an organization by these variables, not a separate equity dashboard on the side, but all of your the outcomes you care about stratified.
Absolutely. Quality, patient safety, experience data. We need our iReport systems when we're looking at, concerns that are being expressed. When all of that needs to be our PARS data, which is really looking at, this is the inside conversation, separate conversation. But yes, suffice it to say, I think we really do need to stratify all of that, right? We need to be able to look at all of that. And that's a way that we bake this in. Again, as I said, this equity has to be baked in, not bolted on, can't be the afterthought. So one of the ways is getting our clinicians used to looking at stratified data. Separate equity dashboard, I can tell you most people probably won't look at it, right? But we have to build it into our existing structures and workflows.
Yeah. So we've got maybe 5 or 10 more minutes here. So Dr. Lyles, I'm going to come back to you in a moment. Dr. Briggs-Mallinson, we talked about your role on the Federal High-Tech Committee. So would love to hear you say a few words, sort of introduce people to what high-tech is, what's happening at the Office of the National Coordinator and Federal Health Policy level, and then in particular, health equity by design. And then Dr. Lyles, we're going to come to you about AI and bias.
Wonderful. And so I will keep these comments brief because I want Dr. Lyles to have a chance to chime in. But as mentioned, I am very proud to be the co-chair of the Federal Health Information Technology Advisory Committee. And this is a group of experts from across the country in which we specifically come together, in which I have the fortunate pleasure of serving with Aaron on it, which we come together to advise the federal government on how health information technology should be designed and implemented here within our country. And so we worked at the privilege and the pleasure of our national coordinator, Mickey Tripathi, and also his team, in which they're all very amazing. And what high tech really does, again, is give input on some of our data standards, as well as the various different policies and legislations that impact health information technology across the entire country. Now, one of the things that recently came into play as a priority for the Office of the National Coordinator is health equity by design. And this is very similar to what Crystal was mentioning and what all of us live and breathe, in which this is not something that's peripheral to our efforts. We have to make sure that even in our systems, that health information technology incorporates principles of equity and justice throughout all that there is. And that's one of the things that we've been doing as high tech, and one of the things that the Office of the National Coordinator has been doing as well. And so some examples of such, for instance, are the Gravity Project, as well as the Gender Harmony Project. Those are two national public collective voices in order to define the various different data standards that need to be incorporated into our certified health information technology that focus on social drivers of health, so that there's greater interoperability between our systems, so that we can really drive improvement in addressing all of those social structural drivers of health. The Gender Harmony Project came to play as well, because we have to be inclusive of thinking about all of the various different gender identity, sexual orientation, and making sure that those are built appropriately with the right terms into all of our health technology systems across the country. And so those are some of the different efforts that we have actually put into place already, so that we can start having standard work and not one system doing one thing, another system doing another. But then also one incredibly important focus for us is how to make sure that we have appropriate data interoperability, not only within our health systems, but within public health, our social service systems, and so many others, in which we have to have better communication in order for us to promote greater health for our communities throughout. And so one of the last things that I'll mention, which is very hot and off the press, was specifically some of our different recommendations that we provided for the new proposed rule underneath HTI, which stands for the Health Data Technology and Interoperability Proposed Rule Update. Now, this was an update to the 21st Century Cures Act, which really focused on what else do we need to do in order to ensure that our certified health technology is meeting the needs of the country, is meeting the needs of our most marginalized and vulnerable populations. And so one of the areas that it was of great interest to me and so many of my other colleagues was really focusing on algorithm transparency. And so we know, and I won't get too much into AI and machine learning, but within healthcare in particular, traditionally we have had something called clinical decision support, which actually gives an idea of, should you do this treatment or that treatment? What type of diagnostic tests? However, we know that those have been very flawed. And we also know that our technology focuses, and especially as we get into AI and generative AI, where we're replicating recommendations, if we're putting in the wrong data, what happens? That gets multiplied 1,000 times over. So if that data has one of those 3 critical errors that I mentioned to you, all we're doing is perpetuating harm. So one of the things, even with the new HTI-1 updates, our recommendations were even additional criteria of making sure that all of these different algorithms, that we know who the populations were that these algorithms were developed from. We also make sure that it was monitored, that it's not perpetuating any type of inequities for various different patient populations, and many, many others. I think we submitted over 60 recommendations. So high tech, we submitted
It
over.
was quite a meeting.
It was quite big, and it was an amazing group, a list of recommendations. But those are some of the things that we do as high tech. So our job is to take from the ground level, from our own expertise, and advise the federal government on how the federal government, and in particular, at least for high tech, the Office of the National Coordinator, in partnership with CMS, FDA, and so many other agencies, that we are driving our country towards greater health equity and justice.
Well, we're very lucky as a country to have you serving in that role. Thank you for sharing that. So let's dive deeper into this AI topic. So we can't, stumble across a panel in 2023 without talking about AI. So Dr. Lyles, let's talk there. Where do you see opportunities and risks in this space as we think, not just large language models, but let's take AI more broadly?
Yeah, I mean, I think the good news is that all the things we've been talking about, to me, apply directly to AI, where the data, and Medel's already said this so eloquently, where the data comes from, how it was sourced, even within our own electronic health record, even if we're doing AI within our own healthcare systems, we need to be aware of how that data is collected at the point of care, how it's been generated, how it's been updated over time, and then the availability of data to make actual algorithms on top of it. We've talked a lot about race ethnicity data. We've done better with that over the last decade or so than we used to in the healthcare systems, but it's not perfect by any means and always needs to be changing as the time goes forward. And then I think we're further behind in sexual orientation and gender identity data. So there's gaps in data, there's existing data that we actually aren't harnessing in the best way possible. And yet we're not, I think equity expertise has not been at the table in terms of bringing that. How do we actually use our people power to use our knowledge about the data that we've captured and what we're building algorithms on to inform our data scientists and others who are making the algorithms, who the potential of those, just to be clear, I'm a tech first person too, up on this panel, is very, very high, right? There's so many processes, so many things in healthcare that should be automated, that are broken, that need much faster, much quicker information at our fingertips. And yet, I would say these core strategies of equity that we've been talking about, the data availability, the use of data, partnering with communities to know what we're building and how we're building them, and what it means to use AI in healthcare. These are strategies that if we don't incorporate that into AI in healthcare, I think we're going to be not only reifying what we've been talking about today, but doing it at a much faster and potentially more risky speed. So the good news is that all the strategies that we're talking about matter. I think the flip side is that AI is moving at a speed in which we need to think about the process and the implementation and the people, the things that we're talking about here. Otherwise, I think those elements will drive some of our decision making. And so we in the tech industry have the ability to not necessarily slow us down by 10 years. I'm not trying to suggest any of that, but really think critically about what we're doing and frankly have impact about what these AI algorithms can do at the point of care. So that's how I think of trying to bring it all together. I actually think it all ties into any technology and specifically the potential for AI moving forward.
Dr. Sine, AI.
I'm really concerned about the speed at which AI is progressing and just what I perceive to be just a real lack of checks and balances and thoughtfulness around the equity implications for safety, and the fact that folks who really understand those implications and kind of are thinking about, again, the folks at the margins and just kind of how these data are going to be used and how, the inputs into them are not at the table, right? And they're not necessarily being consulted about this. So I think that there is a lot of promise with AI, but there's a lot of peril as well. And again, going back to my earlier comment, one of the biggest dangers is this need to move quickly. Because often in moving quickly, you're going to leave people behind, and the folks who are most vulnerable or who are the most, at risk, and for whom the technology could be most detrimental, even while it could potentially be helpful if done in the right way, if it were done intentionally and by design, are the inequities are really going to be perpetuated and just exacerbated, I think, if we aren't really careful. So again, it just speaks to the need for us to be really a lot more inclusive in terms of who's at the table, and kind of having someone there to kind of say, hey, wait a minute, are we thinking about this? Have we considered this? What are the implications? And so I think, let's take advantage of the promise, but also make sure that we're really being attuned to potential risks.
Thank you. So I think we are ready for Q&A. All right. So what's the format for Q&A here? Do we have mics?
We have people on Zoom.
I just want to say, I had to write, but thank you,
It's not
Dr.
on.
Sine.
It's not on.
Hello. Thank you, Dr. Sine. I'm for UCSD Health as well, and for all that you've done with your JEDI team and really bringing everything to. I'm in. Sorry, I'm so nervous. I'm in tech and I'm in enterprise reporting, and I work with data, and I'm also the Tableau lead developer. And what I'd like to know from the panel and from the rest of you, because I've heard this so many times from Dr. Sine, but a lot of my Tableau developers right now, we are discussing real SOGI data. How do we display that in our visualizations? And they keep coming back to me, well, I want to group this data into other. And I said, no, you can't do that. You really need to pay attention. They really thought through these groupings. And so what can I take back to my Tableau developer user group team, and what are best practices around data visualization? You sort of hit on that already, but anything that I can specifically take back to our team and our users to help them understand these groupings and how much time and energy you put into them.
I'm more than happy to jump in on that. Very proud of some of the work that we've done at UCLA Health, specifically about our demographics and how to actually appropriately display the demographics, but then also be able to what we call cascade them up or cascade them down. So we actually use all of this first for race, and I'm just going to say this for everyone who's in the health systems. First for race, we do use the CDC values, and we have level 1 and level 2. So level 1 are all of the standard larger ethno-racial categories that are reported out traditionally to our federal government, to other entities. But we know that most people, a lot of people, may not really identify with just those larger categories. So we have built out in what we call our level 2, and sometimes we go into level 3, much larger ethno-racial categories. And we have this all electronically for all of our patients to self-report their race, their ethnicity, their gender identity, sexual orientation. So race was actually easy, which is why you're asking about the SOGI. So we at UCLA Health, we are a center of excellence for gender health. So we have a lot of gender diverse patients within our organization. And how we did it is that we actually identified all the various different gender identities that we know are most common, but we knew that we were not being inclusive yet until we rolled this out. So as Crystal mentioned, we don't have any words such as other in our systems, but we did do not listed and then put a free text for patients to identify how they see themselves in terms of gender identity and as well as sexual orientation. We did that for race and ethnicity as well. So now how we structured it, because of the visualization, once again, we are, and this is something that's actually currently in process, like gonna go live ASAP. Actually, tomorrow is another meeting on this, but we have it now tiered as well into sort of level 1 and level 2. And so therefore, with some of the various different gender identities that may be less frequent or not part of the standard, like majority of gender identities we see, it does not roll up into like some other category, but at least it's actually in a category that is appropriate, that's respectful, that's inclusive. But if our teams want to drill down into, again, cascade it out, all of the gender identities of all of our patients are all there. And especially when you get more within, for instance, our trans population, and which you may have trans femme, trans mass, which some identify trans femme, trans bi, which is very different from trans male or trans female. So there's all of the beautiful nuances there. And we wanted to capture it all and definitely not kind of like just group it into other categories. So more than happy to show you that mapping, in which we have both the visualization, but on the back end, because we still have regulatory requirements, and unfortunately, this is our job in high tech, to move the federal government and our country forward to being more inclusive and to make sure that we are capturing the data the way that people identify. So unfortunately, we're still not there as a country yet with all of our regulatory reporting. So in the back end, that is when they cascade up into some of the more standard categories for reporting. But when it comes to our visualization, our work as a system, we can see all the different identities.
Additional questions? I think I see one back here.
Yeah, you do.
Hello.
Hi.
So I wanted to go back to.
Sorry, can you tell us which campus you're from and your name?
Hi, I'm from the wonderful UC San Diego. Thank you very much.
Awesome.
Everybody's wonderful. Fun. But anyway, I want to go back to the definition of healthcare as beyond the hospital wall to the communities. And it was great hearing that we need to have people with the lived experiences at the table. I think that's really amazing. And some of the things you described about bringing the expertise into those communities. My question is, what do you see as our responsibility? Because I don't see anything being changeable without a political engagement from us and from them in the communities. And what is our responsibility? And I mean our as a UC, as a community with this privilege, to have that political engagement, empower those communities with the political power that they need to get out of some of the underprivileged that they have. And you know, there's a big force trying to take voices away from those communities. There needs to be an opposing force, right? And I see a role with all of us, including the health system, in being part of that force. So I just wanted to hear, am I off base? What are your thoughts on that? And yeah, I'm going to shut up now. Thank you very much.
Yeah, Dr. Sinay, I'd be particularly curious to hear your
Sure.
response since you've just come from North Carolina a year ago and you may have some observations about our position in California.
They're different.
Maybe one or two.
Just a couple. Thank you for the question. I would say you're exactly right that we have to actually move beyond the walls of the health system. As Medell said, you know, that's also a scary proposition, because what we hear often from our colleagues is, well, what, you know, we can't affect that. We can't cure poverty. What are we going to do? We take care of patients. We do this. This is where this shows, if I may, some egotism, you know, just egocentrism of the health systems. Like we're not the end all be all. So we have to partner, right? Of course, we can't affect all of this ourselves. This is why there has to be the strength of partnerships. We have to partner with community organizations and business owners and schools and all of these other entities who are also pushing for structural and systems level change in their own way. But again, because health is so connected to social and economic position, we have to do this work in partnership. And I think a lot of our communities are empowered, right? But they may not have, they want change, but they often haven't been listened to. They often haven't had people who are willing to kind of stick and stay, come in and actually stay and help them to see how to leverage and harness their power. And so again, that's the purpose of some of the anchor institution work, is about partnering effectively and making sure that we're leveraging our resources, right? So why don't is it possible for some of our IT folks to help as a contribution, right? Many of you, you're talented. Think of all the talent that you have. Can we partner as a health system with some of these small businesses, right, to help shore up their IT staff? Can we give people volunteer hours for doing that? Can that somehow give you some credit on your own job? So we have to think creatively about solutions. But that's why I also think it's really important. And for me, while we started with a lot of the history of structural inequities and structural disadvantage, because it's really important for each of us to be able to see how what was set into place over 400 years ago shapes what we see happening now. If you don't understand that connection, then you think, well, people are just lazy. They don't want to work. They don't want to do this. And they're not, doing things to improve their situation. But that compound disadvantage that was associated with not being educated, or when you were being educated, poor, lower quality education translates to the jobs you get, or the education translates to income, and that the communities, disinvestment in some of these communities that we serve. Like, there are many historical and ongoing reasons why we are seeing the inequities that we see. And so again, I think the key is partnerships. And yeah, we have to leverage our power. I mean, health systems, academic institutions, we're connected with local politicians. We have to drive that change. We can't sit neutrally on the sidelines and say, well, this isn't our boat. It's our job to push politicians and decision makers.
I just want to add something specifically from the UCs, because we're all UC family. And thank you for that question. President Drake has made it very clear that he expects every single campus to engage and partner with community and do something to drive greater prosperity in our communities. In addition to that, the UC health system has also pledged the same thing, which is why we're starting to get a lot more momentum. The University of California system is one of the most powerful systems in this country, with some of the greatest influence as well. Everyone looks to us. And so all of us that are in this room, each and every single one of you all cares about this, or else you wouldn't be in this room. Or you want to learn more about it, or else you wouldn't be in this room. And this is our opportunity to use the voice of the University of California system and to continue to partner and stand up for those various different aspects that we know is right and just. Now, we as the University of California system, we were the first ones that were impacted with the elimination of affirmative action. It started with us in the state of California, here in the UCs, as you all know. But yet, we have continued to fight and move forward of saying, no, our values, our principles, we understand the beauty of diversity. We understand the beauty and inclusivity of people of all identities and all lived experiences. So now this is even more our time after the Supreme Court decisions, because we've been living this for a long time. And so I charge and I encourage each and every one of us in this room that when it comes to fighting, as Crystal said, the 400 plus years of legalized racism, legalized sexism, legalized ism of every single sort, homophobia, transphobia, all of anti-Semitism, Islamophobia. This is our time to lead. And the University of California, we have a voice, and the more we partner and we have that collective voice with all of our various different political leads of UC, we can make a huge difference.
So where are we on time? We've got time for more questions. All right.
Good morning. I'm from UC Merced, and I wanted to ask the question from more from the national side, from sitting on high tech. As respectful to the state of California versus healthcare in the state of California versus other states, I'm coming to this question from a background where multiracial family, I have multiracial family members that are currently in the state of Montana, whereas I will go to a doctor here in California, sit in the office for 45 minutes to an hour, waiting for, say, a 2 o'clock appointment that I'm seen at 3, whereas my family members, son and daughter-in-law, grandchildren, will walk into a facility in Montana and be seen in 5 minutes. Coming back from that, from the inherent discourse that you've said about bias in data and information, remembering that data and information and programming has a person behind it. So even though you have talked about striated information and pure information, is it truly pure information, or is there something behind it? Not only in how we're interpreting it, as you said before, but how it's gathered, but also just in the purest sense of, here's the information. How can we take data without a document or information from behind that data? So kind of twofold question, I guess, for the panel. Thank you.
Yeah.
Maybe I'll jump in and see if I got it right. You can definitely correct me if I got it wrong. In terms of how the data is collected, like even race, ethnicity, and how that data is collected at the point of care and healthcare systems, and sort of, and then how we use it, which we've been talking about a lot. Maybe to make that more concrete, we used to collect race ethnicity data of patients by the clerk looking at somebody and writing down the race ethnicity of that patient to the record. And that was standard practice for a very, very long time. So if we had built any of our systems on that data, fast forward to when we had a system-wide effort to allow every single patient in our systems to self-report their racial and ethnic identity categories when they have time, when, at the point of care, or calling them up and proactively asking them for it, you can imagine that those data are completely disparate from one another. And I think that's what we think when we're saying about doing the collecting data with people and in the way in which they identify. I think we have an opportunity to lead. The federal government could tell us how to collect that data. We can do the minimum, or we can go above and beyond that, which we've heard many examples here, and be the leaders in how we think about those data. And it links back to the policy statement, because I think without data is what we also have a superpower in terms of policy and advocacy. If we don't have the data, we can't actually communicate what kind of changes we need to happen at so they're all, to me, they're all connected to one another. And I think what you're saying is about the process of how we collect data, and hopefully that more concrete example shows you how flawed the data can be unless we change the processes in which how we go about using them, collecting them, interpreting them.
Oh, go ahead. I would say one more thing related to that is Courtney was saying, that's how we used to do it. So I led a project in North Carolina back at UNC a couple years ago, where, we were really trying to delve into the quality of our race ethnicity data and look. And the reality is that there were many of our front desk staff who were still collecting data that way. And the reason was because they said, it shouldn't matter what people's race, ethnicity, or any other aspect of their identity is, but let's just focus on race, ethnicity. We should provide care. We're a public health system, public hospital, safety net. We should provide care for people regardless of their identity, which conceptually is absolutely right. But here's one of those areas where it makes it really challenging, right? The data are how we look to see how we're doing in terms of addressing inequity. So neither point is wrong, right? We wanted people to ask, right? Not make assumptions, but to ask, because that data were going to be how we drive, changes. But so who's right? Both are right. So these are the things that you have to grapple with, because those front desk staff who were saying, I don't ask. And so what would they put down then? They would say unknown, right? We had all this unknown data. We're like, why do we not know this? Or they'd say missing, or they use systems to bypass. And we knew that from the research literature too. Doctors, clinicians don't feel that we should ask this. right? So I think that there are a lot of issues when you really start to delve into the equity lens. There are, our teams are often the smallest teams in any health system, when we really should be the largest, because when you really, any single process, if you really look at it from an equity lens and drill down, it's so much involved.
And one quick piece, and I don't know if this is also what you're referring to, but I did pick up and what you were mentioning, of course, having a family of people that are multiracial in many ways, and the differences in the time being seen by a physician in Montana versus here. And the truth of the matter, we're not going to sugarcoat it. There's still bias within our healthcare
Yes,
systems, without a doubt. And you said it, there's still people there. And part of our job and part of our health system job and part of our country's job is to make sure that people are aware of their implicit biases, those biases in the back of their mind that causes us to treat people differently because of something that we see or something that we hear, and make them explicit so they know that's not right. And there are different care processes, I can tell you, from likely and geographically within our country, that lead to greater efficiencies or less efficiency based off of population density or whatever it may be. And it's just some places you're like that, and some places you are waiting. But the truth is there is still bias. And it's going to take a while until we do eliminate all forms of bias within our healthcare system, as well as within our state and our country. And that is something that we know is real. And that is also something that we have to face head on and correct.
So with that, unfortunately, our time is up. Can you please give a round of applause for our three incredible panelists? Thank you so much. And thank you for great questions from the audience. Really appreciate you all being here.
Thank you so
Thank
much.
you, Erin.
Yes, is this live? Can you hear me? Okay, great. Yeah, I just wanted to add what an incredible group of leaders we have on the stage here. Really just amazing, amazing. Thank you. Okay, so now we are approaching the end, but we're not done yet. We still have sessions that are happening this morning all around campus. And then we have afternoon sessions that are all virtual. So I hope you're going to stick around for some or all of those. One thing I did want to remind you is just claim your prize if you haven't already, because they'll be re-raffled on at 1 p.m. this afternoon if you haven't claimed it. And then finally, I really just wanted to offer some appreciation now. I mean, there's so many people who've been involved in putting this together, the speakers, the presenters, the volunteers. Oops, I gotta click something here. I forgot to click it. And so we've got so many people. I'd like the people who were on any of these groups that I'm about to show you here, the 120 plus volunteers, as well as all of the people supporting this, and also our sponsors. So just, yeah, thank you all. It takes a huge, giant village to do this. We are the University of Community, and this is a showcase for that. So thank you everyone for being here, and I hope you enjoy the rest of your time. Wait, but there's one more thing I just realized. And that is the passing of the buck. So in order to do that, I would like to invite Faye Snowden, Iris Pilaro, and Carol Mitchell from UC Davis, who are receiving the buck. Carol and Iris. Okay, great. Thank you, everyone.
I'm going to say a few words. So a few words. This would not have happened without an incredible team of people behind me. And to illustrate that, I used to be in the Navy many moons ago, and I was sitting in our Bears Lair Command Center, and 3 volunteers, they were in their street clothes, were walking out, and they all had their shirts over their shoulder. They were drinking water. They were hunkered down, ready to go, like they were going to go charge a hill. And I said, oh my God, this is happening. And we have so many wonderful people that have volunteered and done some serious work to make it come together. So I just want to start by saying I've been getting a lot of questions this conference, and the question that I've been getting the most is, would you do this again? my immediate answer is no way. I would not. And I said, as a matter of fact, I'm gonna have my team up here. We're gonna form some Soul Train lines and we're going to happy dance and leg kick this buck all the way to the next hosting campus. Yeah. But and then when we said that we were gonna, that we were gonna volunteer to do this, there was that voice in my head because I had been in the Navy, and those of you who have been in the Navy knows it stands for never again volunteer yourself. So my interior monologue was going, no, but I said, it'll be fun. But it was a very hard thing to do. But, having said all of that, I want to say I was really grateful for this opportunity. And the reason that I was grateful, many of you who know me know that I'm also a writer, which means I'm a word geek. And I love this word that says anneal. And anneal means that when you have a substance like steel, you are heating it and you are cooling it to make sure that it's flexible and that it's softened, right? So when I think about that word and about doing something that you have no idea what you're doing, what comes to me is that how do you know how good of leader you are if those skills are never tested, right? Because anneal also means to strengthen and toughen. It took all the things I have accumulated over the years, all my leadership skills in order to pull this off. And I think a lot of the team also learned some things. I mean, there were things like collaboration, conflict resolution. We had a lot of passionate people on the team with different opinions. There was motivation. How are you going to work your influence? Those people didn't report to me. They didn't report to the work stream lead, but we had this huge job to get done, right? And the other one was, it really brought the team closer together. And for that, I'm going to tell you a story. We were in Bear's Lair with a restaurant, a full bar and everything, right? And we were having problems with CVent. And Sam and Lucci, who are our experts on CVents, were trying to fix it. And we were at the bar and there were all these martini glasses around and we're all like on the computer. They were on the computer, it was their world. I didn't know what they were doing. I'm just like a squirrel trying to get a nut, but they're like this, like trying to figure out what to do. And then Sam sits up and she wears back and I'm waiting for the profound statement. And she goes, y'all, I cannot believe we are in a bar and there's no alcohol. So it was like really like bonded our whole team. And then another thing it did for me, and I hopefully for people on the team, was this thing called prioritization. And prioritization is not a sexy word, but it's really important when you have a huge project, because to me, it means a strive for excellence, but not perfection, right? A strive for excellence means that you invest in the things that you can control, and in the things that you cannot control, you have backup plans, you accept the risk, you try to transfer that risk to someone else. So it really kind of, yeah, you do that. So, so that's what we did. So having said all that, I'm not gonna leg kick, I'm pushing 60, that would be a disaster. But I will say that I am so proud, and I will say that I'm so proud of the team of people. Like I said, it would not have happened without Berkeley Event Services, BIT, Berkeley IT, and also Berkeley AV coming together to make this happen, and all the volunteers and all the supervisors out there who allowed their team members to volunteer for this. So having said that, I'm gonna say hello to Carol. Hello, Iris. And like I said, no leg kicking, but I am going to pass this spot. And one more thing that I want to say is I really want to encourage you to consider doing one thing that scares you. Not a great big thing like this, maybe later, but one thing every day that scares you. If you're going to take a bus, if you usually drive to work, take a bus. This morning I tried the chia seed rice pudding. That scared me, made little bubbles in my mouth, right? I don't know how many people that had it, but if you do, then you're going to get those, test those skills that I know that you all have as leaders, test your potential. So with that, I'm gonna
Hi, I'm Carol, and I think I just entered a 12-step program. So I'm not sure that was a sales pitch. So Iris and I met this morning, and we actually have an accumulative 4 months experience at UC Davis. So I volunteered at this UC Tech. So I have yet to attend a UC Tech where I have not volunteered. So I don't know how this happened, but we both started on the same day in May, and here we are holding the buck. So all we can say is we won't be able to repeat the past because we don't know it. So we'll just forge a new path and expect all y'all to participate.
But we can tell you that it was 110 degrees in Davis this past week, and we will not meet in July next year. But we look forward to seeing many of you next year at UC Davis. And we do take the lessons learned from you, Faye, and from your resilience and inspiration and the themes of this conference to carry them forward. So thank you.